Welcome back to the deep dive. Today we're putting on our medical detective hats, really digging into a fascinating case.
Yeah, it looks straightforward at first glance maybe, but it's actually packed with some crucial diagnostic lessons.
Absolutely. We've got this clinical case study exploring a common but, well, potentially serious presentation. It really tests your clinical reasoning.
It does. Our goal here is to, pull out the most important bits of knowledge, the key insights from this material.
Giving you that shortcut to being really well informed.
Indeed. Syncope, or fainting, it's one of those symptoms, isn't it? It can stem from just a huge array of causes.
From the totally benign to the really life-threatening.
Exactly. So our mission today is to meticulously pick apart the specific patient's story, understand the nuances of the symptoms.
And critically evaluate the diagnostic choices that were presented.
Right. We'll explore not just what the correct answer is, but maybe even more importantly, why those other options, the ones that seem plausible, are actually wrong.
Highlighting those common pitfalls, the traps in clinical reasoning or maybe in exam settings.
Precisely.
So you'll walk away from this deep dive, hopefully, not just knowing the diagnosis, but really getting the hang of the underlying principles, the thought process behind it all.
That's the aim. Feeling confident recognizing these patterns.
Okay, let's get ready to understand what's truly important in these sources. Unpacking the case. The 59-year-old man's story. All right, let's dive into the specifics of our patient then. Picture this. 59-year-old man, seems healthy.
Right.
Suddenly finds himself in the emergency room, brought in by his wife after this, concerning episode, just about 30 minutes before they got there.
So pretty acute presentation. Time is a factor.
Definitely. And the incident itself, it paints a really vivid picture. He was carrying boxes from his house to a truck.
Okay, so physical exertion involved. Moderate, probably.
Right. And while doing that, boom, sudden onset of shortness of breath, quickly followed by losing consciousness. His wife saw it happen, said it lasted about 15 seconds.
15 seconds? And she saw him fall, unresponsive.
Yeah, fell to the ground, completely unresponsive during that time. It's a, classic syncopal event on the surface.
But the context is everything, isn't it?
Exactly. And here's a really crucial detail about afterwards, his post-event status. He was not confused.
Okay. That's important.
Regained consciousness quickly, fully oriented. That piece of information, it starts guiding our thinking right away, doesn't it? Rules out some possibilities.
Definitely pushes things like seizure down the list.
Right. And importantly, he also said no chest pain at the time of the faint or immediately after.
Okay, no acute chest pain. Another helpful negative.
So as we dig a bit deeper into his history, we find some really important clues. Kind of a pattern emerges.
Right.
On questioning, he mentioned this history of episodic shortness of breath and chest tightness.
Episodic. Okay.
Specifically while playing tennis over the past year. And here's the other critical bit. These symptoms always resolved with rest.
Always resolved with rest. That exertional nature, then the resolution. That's a very, very significant clue. Our diagnostic antenna should be twitching.
Totally. Now, his past medical history, remarkably clean.
Yeah, you mentioned that. No serious illness, no regular meds.
Which is, kind of unusual for someone nearing 60.
Yeah.
And crucially, he specifically lacks a history of hypertension, diabetes, high cholesterol, or a family history of early coronary artery disease, CAD.
Right. The classic cardiovascular risk factors, their absence is really telling here.
It makes you question some of the go-to diagnoses, doesn't it?
It certainly should. It forces you to think a bit broader, perhaps.
Okay, let's look at his vitals when he hit the ER. Temp was normal, 36.7 Celsius, pulse 95, respirations 20, blood pressure 102/81.
Okay. Pulse a little up, maybe. Respiration's okay. That BP, 102/81.
Yeah.
It's technically normal, but maybe a bit on the low side for a man his age. Worth noting.
Yeah, keep that in the back of our minds. And finally, the physical exam. It yielded one particularly striking finding.
Okay, what was it?
The doc noted delayed peripheral pulses.
Delayed peripheral pulses. That's not subtle. That's a very specific high-yield finding.
The red flag, right?
Yeah.
For a particular kind of problem.
Absolutely. It really starts to narrow down the differential diagnosis significantly. It's not just a minor detail.
So multiple pieces kind of guiding our thinking now.
It's fascinating how they converge, isn't it? Like carefully placed signposts. The exertional nature is key. The syncope itself happening while carrying boxes.
Aye.
And those prior symptoms, the shortness of breath, the chest tightness, specifically with tennis over the last year.
Not just random events,
Yeah.
tied to activity.
Exactly. They're directly linked.
Hmm.
And then you add that finding of delayed peripheral pulses on exam. That's huge.
Yeah.
It's a major clinical differentiator. It immediately points us towards a specific cardiovascular issue, something about blood flow dynamics or the heart's pumping ability.
Rather than just a general faint or something neurological.
Precisely. And the lack of confusion post-syncope steers us away from seizure too. Each piece, when you put it together, starts building a very specific picture. It creates the strong narrative, navigating the diagnostic maze, evaluating the options and identifying traps.
Okay, so we've got this clear set of symptoms and findings. Exertional syncope, history of exertional chest tightness and shortness of breath, that really telling delayed peripheral pulse finding.
Right.
All in a guy who's relatively healthy otherwise, no major CAD risk factors. So the big question becomes, which of the following is most likely to confirm the diagnosis?
And we're given 8 options. This is where the deep dive really starts.
Let's go through each one. Figure out its purpose. But more importantly, understand why it might seem like a good idea but is actually wrong here.
And what are the common mistakes, the traps people fall into?
Exactly. Mastering that differential diagnosis.
It raises that important question, right? In a clinic or on an exam, how do you systematically rule things out? What assumptions or knowledge gaps lead you astray?
Critical thinking isn't just knowing the right answer.
No, it's knowing why the wrong answers are wrong. That's crucial for making efficient, accurate decisions.
Okay, let's start with the first option. A lot of people might jump to this one, especially hearing chest tightness.
Choice A.
1. Choice A, coronary angiography. 17% of people chose this. Significant chunk. Its main purpose, obviously, is looking for blocked coronary arteries, CAD, especially if someone has angina-like symptoms. Injecting dye, visualizing blockages.
And you can see the logic, can't you?
Totally. Our guy does have that history of chest tightness on exertion. So the immediate thought is exertion, chest tightness. Maybe it's ischemia causing the faint?
That's the hook, the immediate connection people make. But here's where that line of reasoning starts to break down for this specific patient.
Okay, why?
Well, first, while severe CAD can theoretically cause syncope, it's actually pretty rare as the main initial symptom.
Right. You'd usually expect something more dramatic.
Absolutely. Syncope from CAD usually means really extensive disease, maybe a big heart attack happening right then. You'd expect severe, maybe crushing chest pain, often even at rest, profound shortness of breath, signs of heart failure.
And our patient had no chest pain during the faint, and his historical tightness went away with rest.
Exactly. That's a key difference between stable symptoms and an acute event. Plus, and this is a major factor, the absence of those classic CAD risk factors.
No hypertension, diabetes, high lipids, family history.
Right. That significantly lowers the pre-test probability that CAD is the primary driver of his exertional syncope. So, coronary angiography, while maybe considered later if other things are negative, isn't the most likely confirmatory test right now.
Gotcha. So the trap, the common mistake, is just latching onto exertional chest tightness and equating it directly to CAD causing syncope without looking at the whole picture.
Yeah, it's an oversimplification. You ignore the lack of risk factors, the specific nature of the syncope, the resolution with rest. It's a knee-jerk reaction.
Okay, so CAD is less likely given those specifics. What about something more acute and dramatic? 11% considered 2. Choice B, CT angiography.
Right, CT angio. Powerful test, often used for suspected pulmonary embolism, PE, or maybe aortic dissection, both emergencies.
And again, seems plausible on the surface because syncope can be a symptom of both PE and a bad aortic dissection. You need to find those quickly.
True, they're critical diagnoses, and syncope can be there. But crucially, our patient's overall clinical picture just doesn't fit.
How so?
Well, for PE, you'd typically look for other signs. Things like sharp pleuritic chest pain hurts more when you breathe, or sudden, unexplained worsening shortness of breath, maybe leg swelling suggesting a DVT, recent surgery, or immobility.
Don't have any of that. His respiratory rate was normal too.
Exactly. And for aortic dissection, that's usually a sudden, severe tearing or ripping chest pain, often radiating straight to the back. It's excruciating.
Our patient explicitly denied chest pain during the event.
Right. So without those key features, ordering a CT angio for PE or dissection is kind of like fishing in the wrong pond. The clinical suspicion just isn't high enough based on this story.
So the mistake here is using CT angio just because syncope is nonspecific without matching it to the other symptoms. You need that cluster of findings, right?
Absolutely. It's about targeted testing based on the most likely differentials, not just a shotgun approach. Avoids unnecessary radiation, cost, contrast risks.
Okay, makes sense. Let's skip C for now. It was the most popular. Let's look at 3. Choice D, tilt table test. Only 3% picked this, so most people saw it wasn't likely.
Yeah, low percentage there. Tilt table is primarily for diagnosing orthostatic hypotension fainting when you stand up, or sometimes investigating vasovagal syncope.
Right, monitor BP and heart rate while tilting the patient. And it might seem plausible because, well, his blood pressure was on the low side, 102/81, and syncope obviously involves circulation, maybe vasovagal.
That's the potential trap. Seeing a lowish BP or just hearing syncope and thinking orthostatic or vasovagal. But the absolute key here is the trigger.
The precipitating event.
Exactly. Orthostatic syncope happens when you change posture, sitting or lying, to standing. Vasovagal often has triggers like pain, fear, prolonged standing.
Our guy fainted while carrying boxes. He was already upright and active. Exertion was the trigger.
Precisely. Not a postural change, not a typical vasovagal trigger. So context is everything. Low BP doesn't automatically mean orthostatic problems cause this faint.
So the error is ignoring the trigger. If it's exertional, orthostatic, or vasovagal are much less likely culprits for that specific event.
Correct. You have to match the test to the story.
Okay, next one. 4. Choice E, continuous ambulatory ECG monitoring, or Holter monitoring. 10% chose this.
Holter, yeah, standard tool.
Its purpose is clear. Monitor the heart's electrical activity for usually 24 or 48 hours, trying to catch intermittent arrhythmias that a quick office ECG might miss.
Right, looking for those rhythm problems.
And it seems plausible because arrhythmias are a super common cause of syncope, right? Too fast, too slow. Both can cause fainting.
They absolutely are a major cause, no question. But is Holter the most likely confirmatory test in this specific case? Probably not.
Why not?
Couple of reasons. First, his syncopal episodes are described as episodic, probably infrequent. A 24 or 48-hour monitor might just miss the event entirely.
Too short a window?
Could be. For really infrequent stuff, you might need something longer, like an implantable loop recorder, but that's usually later in the workup. More importantly, though, his physical exam noted a regular pulse.
Ah, right.
Now, that doesn't completely rule out all arrhythmias, but it makes a frequent symptomatic arrhythmia causing this specific kind of exertional syncope less likely as the first thing to jump on, especially when you have other strong clues.
Like the exertional trigger and those delayed pulses.
Exactly. Those point much more strongly towards a structural problem rather than a primary electrical issue as the initial focus.
So the mistake is defaulting to Holter for any syncope.
Kind of, yeah. It's vital for unexplained syncope, definitely. But when you have compelling clues like exertion and specific physical findings pointing elsewhere, it's probably not your first or most confirmatory step. Prioritize based on the strongest evidence.
Got it. Okay, how about 5? Choice F, cardiac enzymes. Very few people, only 3% picked this. Seems most recognized it wasn't right.
Yeah, low uptake there. Cardiac enzymes, troponins, CKMB, they're primarily for diagnosing acute coronary syndrome, ACS, heart attacks.
Usually ordered for new or worsening chest pain, especially at rest, right? Indicates acute heart muscle injury.
Precisely.
But one might argue, well, our patient did have a history of chest tightness, so maybe cardiac involvement.
True, but again, the details matter hugely. His main presentation now is syncope, not acute, severe, ongoing chest pain. That's the trigger for immediate enzymes.
And his historical chest tightness was exertional, resolved with rest. Stable pattern, not acute.
Exactly. That's more like stable angina, a chronic thing, not an acute event needing urgent enzyme checks. Plus, again, no CAD risk factors makes ACS less likely for this presentation. Enzymes detect acute injury, and his story doesn't fit an acute event right now.
So this highlights that reflex. Hear chest, order enzymes, but you need to evaluate the type of symptom, the acuity, the whole picture.
Right. Appropriate test utilization. Don't just order everything.
Okay, next. 6. Choice G, carotid duplex ultrasonography. 6% chose this one, ultrasound of the neck arteries.
Looking for carotid stenosis, narrowing of the arteries supplying the brain.
And the thinking might be, well, syncope is about blood flow to the brain, carotids supply the brain, maybe a blockage there caused the faint.
It's a logical connection on the surface, but isolated syncope is actually rare as the main symptom of carotid stenosis.
Really? What's more common then?
Usually, symptomatic carotid disease causes focal neurological symptoms, things like TIAs, transient ischemic attacks, or strokes.
So like weakness on one side, speech problems, maybe temporary vision loss in one eye.
Exactly. Amaurosis fugax, that temporary blindness. Our patient had none of those focal neurological signs. It was a global event, fainting.
And the physical exam.
The delayed peripheral pulses and the lowish blood pressure, those are not typical of carotid stenosis. They point much more towards a central problem like the heart's output, not a blockage just in the neck.
So the trap is mixing up global brain hypoperfusion syncope with a focal problem like carotid stenosis, or not recognizing that the physical findings point away from the carotids.
Precisely. The whole clinical picture just doesn't support carotid stenosis as the primary cause here.
Okay, last wrong answer. 7. Choice H, electroencephalogram, EEG. Only 1% picked this, which is good.
Yeah, very low percentage. EEG is for looking for seizure activity in the brain.
Plausible maybe, because any loss of consciousness can sometimes look like a seizure, especially if not well witnessed.
True, the distinction can sometimes be tricky, but our patient's story argues strongly against it.
How so?
No history of convulsions, no known triggers like electrolyte problems, but the absolute key piece of information.
Right. A lack of confusion afterwards.
Exactly. He was not confused after regaining consciousness. The absence of that postictal state, the confusion, drowsiness, disorientation after a seizure, makes a seizure highly unlikely as the cause of this episode.
Right. If you'd bitten his tongue, been incontinent, confused for minutes, different story.
Totally different. Plus, again, those positive cardiovascular clues, the delayed pulses, the blood pressure, push us strongly towards a cardiac cause, not a primary neurological event like a seizure.
So the mistake is thinking EEG for any loss of consciousness. You really need those hallmarks of a seizure, the movements, incontinence, and especially that postictal state before going down that road.
Correct. Follow the strongest clinical clues, the aha moment. Why echocardiography is key. A deep dive into aortic stenosis.
Okay, so we've methodically gone through 7 other options, understanding why they don't fit this specific patient's presentation. Mismatched symptoms, wrong context, wrong test utility.
Yeah, we've eliminated a lot based on the specific details.
Which leaves us with transthoracic echocardiography, choice C, the correct answer, chosen by 49% of people. Nearly half got it right.
Good.
But this isn't just about picking the winner, is it? It's about understanding why it's the right test. How all those clues we gathered, the exertion, the symptoms, the pulses, suddenly click into place.
This is definitely the aha moment,
Me too.
where all the pieces fit together beautifully if you connect the dots.
Yeah.
That combination, the exertional symptoms, syncope-carrying boxes, the history of shortness of breath and chest tightness with tennis, combined with that crucial physical finding of delayed peripheral pulses, it points overwhelmingly towards one specific diagnosis, severe aortic stenosis.
Aortic stenosis. Okay.
Yeah.
So let's dive deep into why echo is the key here and how AS explains everything we've heard about this patient.
Absolutely. Transthoracic echocardiography, or TTE, is the gold standard for diagnosing AS. Why? Because it lets us see the aortic valve directly.
Visualize it.
Yeah. We can assess its morphology. Is it thickened, calcified, maybe congenitally abnormal, like bicuspid? We can measure how well it opens, quantify the obstruction severity, and see the impact on the heart, especially that main pumping chamber, the left ventricle.
Gives you objective, real-time data.
Exactly. Now, let's master the why, the pathophysiology of aortic stenosis, and how it perfectly explains our patient's symptoms.
Okay, lay it out.
So, in the early stages, AS can be totally asymptomatic when you're just resting. The heart, especially the left ventricle, is strong enough to compensate, pushing blood through that narrowed valve without you noticing.
Which explains why he might have felt fine until he really exerted himself.
Precisely. The compensation has limits. Now, during physical exertion, carrying boxes, playing tennis, what happens physiologically?
Muscles need more blood, so blood vessels dilate.
Right. Peripheral vasodilation. The blood vessels in your limbs and muscles open up to increase blood flow. This causes a drop in systemic vascular resistance. The resistance the heart pumps against throughout the body decreases. But here's the critical part. If the aortic valve is severely stenotic, severely narrowed, it creates a significant fixed obstruction right at the exit of the left ventricle.
Like a bottleneck.
Exactly. A bottleneck stopping blood from getting out into the aorta and the rest of the body effectively.
So the vessels are dilated, asking for more blood.
But the heart cannot increase its output adequately to meet that demand because of the fixed blockage at the valve. The left ventricle is working like crazy, but it's hitting a wall, literally the stenotic valve.
So blood pressure drops relatively.
Especially during that peak exertion when demand is highest. The heart just can't keep up with the need created by the peripheral vasodilation against that fixed obstruction.
And that explains the symptoms.
Perfectly. It leads directly to the classic SA triad of severe aortic stenosis: syncope, angina, and dyspnea.
SAD, okay, break that down.
First, syncope. The drop in systemic blood pressure, combined with reduced blood flow getting to the brain's cerebral hypoperfusion, causes fainting or dizziness. That's exactly what happened when he's carrying boxes. Brain wasn't getting enough oxygenated blood.
Makes sense.
Second, dyspnea, or shortness of breath. The heart can't pump blood forward effectively, so pressure backs up into the left atrium, then into the pulmonary veins and capillaries in the lungs.
Like a traffic jam.
Exactly. That increased pressure in the lungs causes shortness of breath, especially with exertion. That's his symptom playing tennis, lungs getting congested.
Okay. And the third one, angina.
Angina pectoris, the chest tightness, also directly linked to AS. It happens because there's reduced blood flow getting into the coronary arteries themselves, often due to the lower pressure in the aorta just past the valve. And the left ventricle is working much harder, demanding more oxygen. So you get the supply-demand mismatch for the heart muscle itself, causing ischemic pain angina, even if the coronary arteries are perfectly clean.
Wow, so the angina isn't necessarily from blocked coronaries in this case.
Correct. It's a consequence of the severe valve stenosis itself.
So putting it all together, his exertional syncope fits perfectly. His exertional dyspnea and chest tightness, playing tennis, resolving with rest, classic AS.
Absolutely textbook.
And that physical exam, finding the delayed peripheral pulses. You called the hallmark. Explain that again.
Right. Pulsus parvus et tardus. Parvus means small or weak. Tardus means slow or late. Because the blood flow out of the left ventricle is obstructed and slowed by the narrow valve, the pulse wave you feel out in the periphery, like in the wrist or foot, is weak and rises slowly.
Instead of a sharp, quick pulse.
Exactly. It's a really specific physical sign of that fixed outflow obstruction, a crucial clue pointing right at AS.
Even his blood pressure, 102/81, fits.
It can, yeah. In severe AS, systolic pressure can be normal or low, and the pulse pressure, the difference between systolic and diastolic, often narrows, consistent with reduced cardiac output, especially under stress.
And you mentioned a murmur, even though it wasn't explicitly in our notes.
Right, for completeness. The classic auscultation finding in AS is a crescendo-decrescendo systolic murmur. Sounds like it gets louder then softer during the heart's contraction.
Where do you hear it best?
Best heard at the right upper sternal border, where the aorta comes off the heart. And it often radiates up towards the carotid arteries in the neck. Another key diagnostic feature clinicians listen for.
So the mastery here is really about synthesis, isn't it? Taking all these pieces, exertional symptoms, the specific pulse finding, the age, the lack of other risks, the resolution with rest, and seeing how they all point directly to aortic stenosis.
Exactly. And understanding the pathophysiology, the why behind those symptoms, that's what cements the knowledge. It's not just memorizing facts, it's understanding the mechanism. That's how you connect the dots confidently.
Okay, so the echo confirms it. And we actually have the numbers, the quantitative data from an echocardiogram report that would confirm this. What are we looking at, and what do these measurements tell us definitively about the severity?
Right. The echo gives us the hard numbers. It moves from suspicion to confirmation and grades the severity. Let's look at the key measurements provided.
Okay.
First, the aortic valve area, or AVA. The report gives us AVA 1.04 centimeter valves. Now, a normal aortic valve is wide open, usually 3.0 to 4.0 centimeters.
Much bigger.
Much bigger. An AVA less than 1.0 centimeters is generally considered severe aortic stenosis. So 1.04 centimeter totus is right there, borderline severe to severe, clearly significant obstruction. Think of a doorway almost shut.
Okay, definitely narrowed.
What else? Next, AV max, the maximum velocity of blood flow across the valve. The report says AV max 4.01 meters. Normal velocity is usually less than 2.01.
How much faster here?
Much faster. A velocity over 4.0 meters is another strong indicator of severe AS. This number, 4.01, clearly points to severe disease. The blood has to speed up dramatically to squeeze through that tiny opening.
Like water through a narrow nozzle.
Exactly. Then there's the AVG, the mean pressure gradient across the valve. The report shows AVG 64.3 millimeter Hg. Normal is low, usually less than 20 millimeter Hg.
And over 40 is severe.
Right. A mean gradient over 40 millimilli Hg signifies severe AS. Our patient's 64.3 millimilli Hg is significantly elevated, confirming severe obstruction. It reflects the huge pressure difference the left ventricle is fighting against.
The heart is really straining.
Immensely. The report also mentions AVVTI, velocity time integral, another flow measure used to calculate the AVA, which is consistent, and things like cardiac index, TOA, which was noted as low.
Indicating reduced overall cardiac output.
Correct. Consistent with severe AS causing symptoms like syncope and dyspnea because the body's needs aren't being met. And there's another metric, ZZ, likely another specialized measurement contributing to the overall picture.
So these numbers, taken together,
they directly and definitively confirm severe aortic stenosis. They align perfectly with every clinical clue, the history, the symptoms, the physical exam. This is why echo is the confirmatory test. It gives objective proof and severity grading, deepening our understanding. The broader context of aortic stenosis.
Okay, so we've nailed the diagnosis. Severe aortic stenosis, confirmed by echo, perfectly explaining the clinical picture. What does this all mean in the bigger picture? Beyond just this case, what are the key takeaways?
Well, reflecting on this case, what stood out most to me was how the absence of those common CAD risk factors actually became a positive diagnostic clue, steering us away from the default assumption.
Yeah, that was counterintuitive, wasn't it? Usually you look for risk factors confirming a diagnosis. Here, their absence pointed elsewhere.
Exactly. It forces you to challenge assumptions. Chest tightness on exertion doesn't always equal CAD, especially when other pieces, like the delayed pulses and lack of risk factors, don't fit. That's the deep dive lesson. Look at the entire constellation, the whole story the patient's body is telling.
Don't get tunnel vision on one symptom.
Precisely. And connecting this more broadly, understanding AS is just crucial. It's progressive. And recognizing those said symptoms, syncope, angina, dyspnea, is paramount.
Why paramount?
Because the onset of symptoms marks a critical turning point. For someone with severe symptomatic AS, the prognosis without intervention, usually valve replacement, is really poor.
How poor?
Often measured in just a few years. Maybe only 2-3 years average survival. Once heart failure symptoms like significant dyspnea appear, it becomes urgent. Accurate diagnosis isn't just academic, it's life-saving.
Wow. That really ups the stakes.
It does. This case also just reinforces the power of fundamental clinical skills. A good history, really, listening to the details like exertion and rest, and a careful physical exam finding those delayed pulses.
They provided such strong clues early on.
Incredibly strong. They directed the whole workup. Even with all our amazing imaging, you just can't replace good bedside skills. They remain critical.
And the differential diagnosis process.
This case was a masterclass in it, wasn't it? Systematically ruling out other plausible diagnoses by understanding their specific features and why the tests for them weren't appropriate here. It's not just finding the right answer, it's knowing why the others are wrong. That methodical approach is key to clinical mastery.
So once you've made this diagnosis severe, symptomatic AS, what happens next for a patient like ours? What are the treatment options?
Great question. Diagnosis is step one. For symptomatic severe AS, the definitive treatment is aortic valve replacement. Basically, you have to fix the broken valve.
How do they do that?
Two main ways nowadays. There's surgical aortic valve replacement, SAVR, that's traditional open heart surgery. They remove the diseased valve, put in a new one, either mechanical or bioprosthetic, made from tissue.
Standard for a long time.
Right. Highly effective. Then there's transcatheter aortic valve replacement, TAVR. This is less invasive.
The one they do through the leg artery.
Often, yes, or sometimes other access points. They thread a new valve up on a catheter and deploy it inside the old diseased valve. It's been revolutionary, especially for older or higher risk patients.
So for our 59-year-old guy, relatively young, otherwise healthy,
SAVR, the open surgery, would likely be the first consideration, especially if he's a good surgical candidate. They discuss valve types. Mechanical lasts longer, but needs lifelong blood thinners. Tissue valves don't usually need thinners, but might wear out eventually.
So a detailed discussion needed.
Absolutely. A multidisciplinary heart team weighs all the factors, the patient's health, anatomy, preferences, to recommend the best approach. But the key point is, once symptoms like syncope appear with severe AS, intervention is critical. Valve replacement is needed to improve symptoms and, crucially, extend life.
Restoring proper heart function is literally life-saving here.
It really is.
And thinking about why he developed this at 59, what are the common causes of AS in someone that age, especially without those typical risk factors?
Good point. The most common cause overall is age-related calcific aortic stenosis. Just wear and tear over decades, calcium builds up, valve stiffens. 59 is maybe a little on the younger side for it to become severe, but definitely possible.
Okay. Any other main cause?
The other major one, especially in younger patients like him, is a congenital bicuspid aortic valve. Instead of the normal 3 leaflets, the valve develops with only 2.
Born with it.
Yes, and that abnormal structure makes it much more prone to wearing out, calcifying, and becoming stenotic earlier in life than a normal tricuspid valve. So in a 59-year-old, particularly without strong atherosclerosis risk factors, you'd strongly suspect either early calcific disease or an underlying bicuspid valve.
Got it. Reinforces that AS isn't always tied to the same things as coronary disease.
Correct. Different process, often.
Wow. What an incredible deep dive. We started with, a man collapsing, carrying boxes, seemingly simple event. And through really careful analysis, digging into the history, the exam,
Picking up on those key clues.
we uncovered this serious underlying heart condition, severe aortic stenosis, echo confirmed it, and the pathophysiology just explains every single symptom.
It really does highlight that beautiful interconnectedness, doesn't it? Symptoms, the underlying mechanism, the diagnostic tests. It teaches us to listen really carefully to the body's signals, especially under stress or exertion, and the importance of picking the right test to get that definitive clarity.
Absolutely. So what does this all mean for you, our listener? Well, next time you hear about someone getting dizzy, fainting, or having chest discomfort, specifically during physical activity, remember this story.
Yeah, don't just brush off exertional symptoms. They can be the body's early warning system.
And the absence of those typical risk factors doesn't mean everything's okay, does it?
Definitely not. Serious conditions can occur without them.
So it raises an interesting question to think about, maybe. What other common, maybe seemingly benign symptoms that people experience in daily life might actually be the body's subtle way of signaling something serious underneath, something that needs its own deep dive?
That's a great thought. Keep questioning, keep learning, keep connecting those dots between what you see and what might be happening underneath.
Thank you for joining us on the deep dive, and we look forward to our next exploration.